Welcome to the Ultrasound of Head and Neck Anatomy lecture. My name is Virag Shah from the Department of Emergency Medicine. Special thanks to Dr. Mary Beth Johnson in organizing this lecture content. In this module, we will initially be focusing on neck ultrasound. We will start by discussing carotid artery and internal jugular vein anatomy and physiology. We will then discuss thyroid ultrasound anatomy. Finally, we will briefly review the anatomy of the eye from a sonographic perspective. Here is an ultrasound clip of the carotid artery, internal jugular vein, and thyroid gland in transverse view. Assuming the sonographer is using the proper orientation when scanning this patient, can you tell which side of the neck we are looking at? Recall that with conventional orientation, the probe marker, as indicated here, should be towards the right side of the patient when scanning in a transverse plane. Therefore, we are looking at the right side of the neck. We will return to this ultrasound clip after reviewing the anatomy in more depth. Recall the basic anatomy in the neck. Note the relationship between the carotid artery, the internal jugular vein, and the thyroid gland. We will be surveying these structures using ultrasound in this module. For this ultrasound module, we will be using the linear probe. Its high frequency is ideal for visualizing the superficial structures in the neck. When scanning the structures in the neck, the patient should be in a supine position with their head turned away from the side being scanned in order to increase visibility. In this picture, the operator is scanning in the transverse plane. Let's start with the vascular structures in the neck. Depicted here are the internal jugular vein and the common carotid artery, demonstrating their relationship to one another and to the sternocleidomastoid muscle. Note that the internal jugular vein lies lateral to the carotid artery. Here, you will notice the same anatomy taken as a cross-section. This cross-section anatomy depicts the structures you will visualize when scanning in the transverse plane. Make note again of the internal jugular vein, the common carotid artery, the thyroid gland, and the trachea. Here is the transverse view of the neck anatomy once again. Notice the characteristics of the carotid artery in transverse plane. It maintains a circular appearance with a fixed size due to its muscular wall. Notice also its pulsatile quality. Contrast this with the characteristics of the internal jugular vein. Due to its much thinner muscular wall, it varies in size and shape depending on the amount of venous distension. Venous distension can be increased with the Valsalva maneuver or with Trendelenburg positioning of the patient. Its size also varies with respiratory and cardiac cycling. Recall Doppler technique as presented during the Introduction to Ultrasound module. In this first clip, we see the carotid artery and internal jugular vein in transverse view. Recall that color represents directionality. When we fan the probe to change from aiming cephalad to caudad, the color in each vessel changes, reflecting the change in Doppler signal directionality. In this video, can you determine which side of the neck we are looking at if the probe marker dot is oriented towards the patient's right? This is the left side. The depth setting of the two clips is different. Notice that the shallower setting, seen on the right-sided panel, allows a larger display size of the structures of interest. In this video, we see the longitudinal view of the carotid artery and jugular vein side by side. Notice the variability in the size of the jugular vein. When you are scanning, you will be able to take notice of the more laminar flow characteristic of veins. Here, we see color flow Doppler in the carotid artery in the longitudinal axis. Notice the characteristic pulsatile quality of arterial flow. Notice the spectral Doppler pattern of arterial flow as we look at the carotid artery. Spectral Doppler can be evaluated in both transverse and longitudinal orientation. These Doppler velocities are helpful in determining whether or not stenosis is present in arteries. In contrast, here we can observe the more laminar quality of venous flow as demonstrated in spectral Doppler mode. Notice the difference between the Doppler effect of arterial and venous flow shown here. We see the pulsatile quality of the artery and the more laminar flow seen in veins. In this video of the carotid artery and jugular vein in transverse view, light neck compression is being applied. With light compression, we see that the jugular vein fully compresses, whereas the carotid artery does not. This is a useful distinction between the two vascular structures. This characteristic of venous compressibility is applied when evaluating for blood clots in venous structures. Blood clots prevent compressibility. Here, we see a blood clot in the internal jugular vein preventing compressibility. We also see that when color flow is applied, as shown in the right-handed panel, there is an absence of filling in the vein. When looking for carotid artery disease, ultrasound provides us with diagnostic tools. We are able to grossly visualize the presence or absence of plaque. We are also able to take carotid velocity measurements with spectral Doppler. The velocity differentials between the common carotid artery and the internal carotid artery allow us to gauge the degree of stenosis. Carotid stenosis is a large contributor to cerebrovascular accidents. When scanning the carotid artery, we will be scanning the artery in transverse and longitudinal planes. Scanning in the transverse plane, we can see when the common carotid artery bifurcates into the internal carotid artery and external carotid artery, as we slide in a cephalic direction up the neck. Notice the bifurcation as this video repeats its loop. Scanning in the sagittal plane, we can also appreciate the common carotid bifurcation. This is a transverse and longitudinal image of plaque causing obstructed flow in the carotid artery. In this still image, we see another diseased carotid vessel. One can observe that the artery does not fill with color when color flow is applied. Here is the same vessel in the longitudinal axis. Again, it can be observed that there is no flow and no Doppler signal detected in this occluded artery. Let's move on to the thyroid gland. Recall the relationship of the thyroid gland to the carotid artery and internal jugular vein as depicted in the images. The thyroid gland is made up of the right lobe, the left lobe, the isthmus, and finally the pyramidal lobe. Note that the pyramidal lobe appears as a superior extension from the isthmus. This lobe varies in length and is actually a vestigial remnant of the thyroglossal tract. The pyramidal lobe is oftentimes not present and has been reported by various studies to be present in between 10 to 45% of the population. When scanning the thyroid gland, we can scan in both sagittal and transverse planes. Measurements are taken of the maximal length when in the sagittal or longitudinal plane, and maximal thickness is measured in 2 dimensions of width and depth. Normal thyroid length ranges from 4 to 6 centimeters, and normal thickness is from 1.3 to 1.8 centimeters. Thyroid volume is then calculated from these measurements. Various sonographers and institutions use different volume equations to assess total volume. Some machines also contain software that is able to make the calculation at the bedside. Volume assessment is useful in diagnosing goiter and tracking the success of treatment. It is also used for rigorous iodine dose calculation when treating Graves' disease. For our purposes, we will be focusing on making raw measurements. Let's revisit this video clip from earlier in the lecture. Notice that the trachea is located medially on the right side of this video clip. The tracheal cartilage ring typically casts a posterior shadow. The trachea here lies just deep to the thyroid isthmus. Notice the characteristics of the thyroid gland in cross-section and its close relationship to the carotid artery and the trachea. Notice the homogeneous echotexture of the thyroid gland. Additionally, the thyroid gland also notably appears more echogenic than the overlying musculature. In the next looped video clip, the operator is scanning the thyroid gland in the transverse plane from cephalic to caudate as illustrated here. When scanning through the thyroid gland, find the view that displays its maximal width. Here, the sonographer has found the maximal width. The image is subsequently frozen and a measurement is taken. Here is a measurement of the thyroid width. In this same transverse plane, the sonographer may continue to scan until the maximal depth is detected. Once again, the image can be frozen, as shown here, and a depth measurement is taken. Now we will scan in the longitudinal axis of the thyroid. When scanning in the longitudinal axis, you can see that it is sometimes difficult to obtain a view of the entire length in one image. More modern machines may have a feature that allows the linear probe to display a wider beam. Notice the trapezoid function indicated here, which essentially has the effect of widening your view such that the entire thyroid in its longitudinal aspect can be measured at once. Previous to this, sonographers would rely on splitting the screen and measuring half of the thyroid in each still and adding the values together. Here one can see that using the widened view feature enables for a more accurate measurement in a single frame. Here we see the thyroid in transverse plane again at the level of the isthmus. Notice the reverberation artifact that we see from the trachea as it casts its echo-free shadow. The isthmus is not used in calculating the total volume of the thyroid gland. Thyroid abnormalities appreciated on ultrasound imaging include calcifications, cystic lesions, and growths. This image portrays the thyroid gland in the longitudinal axis. There are two abnormalities. The first is being measured in this image. Notice the loss of homogeneity in this particular solid growth. The second growth is the more obvious growth that appears to be irregularly cystic. Color flow is sometimes used to better characterize some thyroid lesions. Radiologists use criteria to determine whether or not it is necessary to perform a biopsy of the thyroid lesions diagnosed on ultrasound. We will now briefly discuss the sonographic appearance of the eye. First, we will review the anatomy of the eye on ultrasound. This will be followed by a demonstration of the scanning technique used to evaluate the eye. Finally, we will conclude with some examples of how the eye can be rapidly evaluated on ultrasound in the patient care setting. Let's review some relevant anatomy using this illustration of the eye. From an ultrasound perspective, we simply need to focus on larger chambers and eye structures. This is the anterior segment, or anterior chamber, which extends from the cornea anteriorly to the iris and pupillary opening posteriorly. The next structure encountered, in terms of depth, is the lens. Deeper to this is the posterior segment, which contains the vitreous body. And here, the optic nerve is noted to enter the eye, forming a raised entry point of the retina called the optic disc. Finally, located temporally or lateral to the optic disc is the macula, which contains the fovea that is responsible for high acuity vision. Here is a fundoscopic image which helps reinforce the lateral to medial relationship of the macula and optic nerve. The optic nerve is the bright area where all the blood vessels converge. It is located at the nasal aspect of the retina, or medially. The macula is located at the temporal aspect of the retina, or laterally. And here is a sonographic representation of the same anatomy. Here is the anterior chamber ranging from the cornea in the near field to the iris at the deepest aspect of the anterior chamber. Here is the lens, which typically is anechoic with a hyperechoic deep border. The posterior segment containing the vitreous humor is the large anechoic area indicated here. And the curvilinear contour here represents the retina. Finally, the optic nerve is noted in the deep field here. The video clip can be viewed without any label here. When scanning the eye, the linear transducer is used. Recall that a high-frequency transducer such as the linear probe will allow the examiner to view higher resolution details at a lower depth. Fortunately, we do not need an immense amount of depth to perform the eye exam. Therefore, this probe is appropriate. Recall that the thermal index is an indicator that we can use to determine the relative potential for a tissue temperature rise. This is relevant for the eye, which is particularly vulnerable to thermal hazard since the lens and the aqueous and vitreous humors have no cooling blood supply. Overall, the soft tissue thermal index, or TIS, should be minimized as shown here when scanning the eye. Ensure that you use adequate amounts of gel when scanning the eye. You'll want to heap it up to prevent placing significant pressure on the eye. Additionally, cooled or slightly chilled gel tends to heap up better due to the thicker viscosity. Some examiners prefer using a waterproof transparent cover to keep a clean scanning area and shield the eye from gel. It should be noted that it may prove difficult to make a nice seal and prevent any air bubbles from forming beneath the dressing. A significant amount of air will result in scatter of sound waves and a poor image. Here, the patient's eye is scanned in both the transverse and longitudinal views. Notice how the sonographer may use their fourth and/or fifth digits to rest against the bridge of the patient's nose or the patient's cheek to create an anchor point that prevents placing too much pressure on the eye. Here again is an example of a normal ocular ultrasound. Notice the smooth, curvilinear retinal contour. In other words, the normal retina is continuous with the other posterior elements of the globe and is not visible as a distinct structure. Here is an example of how ocular ultrasound can be used to detect pathology. This is a retinal detachment. Notice that the retina appears as an undulating hyperechoic membrane that appears to have been lifted off the posterior surface of the eye. Here is another example of a retinal detachment. Notice that the patient is demonstrating ocular kinesis by moving their eye while the exam is being performed. This concludes the head and neck module. Thank you for your kind attention.